I'm very excited that so many of you have joined us on what I was saying was seemingly a perfect summer afternoon, at least if you like cool summer weather. So I'm very grateful to be able to be hosting this presentation with the Department of Epi. I'm Kathy Sikkema, the chair of SMS, for those of you from Epi that maybe I haven't met, but probably should know. So we're very pleased to have Melissa DuPont-Reyes join us today. She's, many of you know her, so I will very briefly introduce her. She's an assistant professor in the Department of Epidemiology and Biostatistics in the School of Public Health at Texas A&M University. You may know she received her PhD in epidemiology here in 2017 after she'd received her MPH from Rutgers. She was a part of the NIMH T32 psychiatric epidemiology training grant while she was here, and then went on to postdoctoral training focusing on Latinx populations when she completed a fellowship in 2019 at the Latino Research Institute at the University of Texas, Austin, prior to taking this current faculty position. Just very briefly, an overview about her work. Melissa's research program generally aims to understand adolescent mental health, help-seeking processes in terms of how that's working towards improving mental health service utilization, and ultimately the lives of young people with ill mental health. Dr. DuPont-Reyes' research is really an interesting combination, I think, of SMS and epidemiological approaches, and that she's strongly rooted in interdisciplinary theory and frameworks that draw on a number of disciplines that range from sociology to gender and ethnic studies, implementation science, health communication, and of course, epidemiology. I think she'll probably tell us about this when she tells us about her work in a moment, but she recently received the highly competitive Robert Wood Johnson Foundation Pioneering Ideas Award, which is focused on exploring the future to build a culture of health, where she'll be focusing on mental health stigma in Spanish media to encourage help seeking for mental health issues. One other point I'll make is she also is in the process of submitting a KO1 application to NIMH to focus on identifying effective implementation strategies for mental health anti-stigma curriculums in schools. So before I introduce her, I'm going to try to figure out which person isn't muted. So 1 second, I will figure that out in a minute. Charlie, if you want to add while I try to figure out who to mute, please go ahead, or we can
I think someone has the power to mute all or something like that.
Yeah, I'm just trying to get there while I'm okay. Okay, everyone all right now? I think we're good now, as long as we didn't mute Melissa. So I think we're fine.
I think so, yeah.
Okay, great. So we've asked Melissa to talk for 40+ minutes and hold our questions until the end, but we'll have a good amount of time for questions then. So Melissa, please proceed. We're excited. Your title is right there, but we're very interested to hear about intersectionality and mental health equity from your research agenda perspective.
Okay, great. Thank you for that introduction, and thank you everyone for coming to my talk today and taking the time to listen to my research. So the title of my talk is Leveraging Intersectionality Towards Achieving Mental Health Equity, a Research Agenda. And I begin with this image. It's a Colombian indigenous mola print, which is my heritage, because it reminds me of the upstream and downstream public health paradigm that might resonate throughout my talk. So just a little bit of my background in academic and research training. Very early on in my formal education at BU, I was interested in both humanities and social sciences, as well as medicine and public health and the intersections of art and science. You know, I majored in Latin American studies and Spanish language literature, but I also was pre-med and I took my first EPI course. So I was always very early on interested in many different disciplines that have very recently come together for me in a nice way. And then from there, I pursued my graduate level training in epidemiology. In research, as Kathy mentioned, I was a PET fellow in the Columbia program while I was a doctoral student. And then I was attracted to integrating social sciences during my postdoc and getting some more interdisciplinary training. And so I completed a fellowship, the Carlos Castañeda Postdoctoral Fellowship at the University of Texas at Austin at the Latino Research Institute and Center for Mexican American Studies. And while I was there, I learned to make my work interdisciplinary and incorporate frameworks pertaining to race, ethnicity, gender, structural racism, particularly intersectionality, and then also other various important and different perspectives. Related to intersectionality, I was really attracted to it for understanding stigma. I was a long-time mental health stigma researcher throughout my training, and I felt like intersectionality could inform stigma across intersections of various social identities and how it influences mental illness stigma in particular. And more recently, I completed a media and medicine certificate program at Harvard Medical School and the Department of Global Health and Social Medicine, which will inform the Robert Wood Johnson Foundation Award, which I'll speak at towards the end of my talk. So my talk outline is going to begin with my research program and its motivation, and then I'll provide two examples of specific studies that I've conducted on the intersectional study of mental illness stigma, looking at across race, ethnic, and gender differences, and then identifying sources of these inequities that I found in the first study. And then towards the end of my talk, in the third section, I'll talk about future research that aims to mitigate these inequities in mental health stigma in the population. The first project takes a tailored, targeted approach, while the second project is more of a one-size-fits-all implementation approach, each having its purpose in addressing inequities and stigma. So for the first section, I'm going to begin by just describing U.S. adolescents in context, because we don't always know, what the population entails. So there are about 42 million adolescents in the U.S., and they comprise 13% of the total U.S. population. But what's important to know about adolescents in the U.S. is that 1 in 2 live in poverty or a low-income household, and 1 in 2 also identify as a race ethnic minority group. And this is from 2016 data, which has been expected to worsen, in the years to come in terms of poverty and low-income households, especially after the pandemic, and in terms of race ethnic minority group. It's projected to increase to about 2/3 by 2060. And related to racial and ethnic minority groups in the US, particularly adolescents, it's important to note that these groups face a socioeconomic environment of inequality, which means they have greater exposure to racism, discrimination, violence, poverty, which all have deleterious effects on mental health. And regarding mental health context for adolescents, for depression and anxiety in particular, racial and ethnic minority youth versus white youth consistently report poor health outcomes. And this has been demonstrated in these large epidemiological national survey studies, in the National Comorbidity Study of Adolescents, for example, the National Longitudinal Study of Adolescent Health. But it's also been shown in community and school samples, as demonstrated by this review by Anderson. And then it's also demonstrated in the Youth Risk Behavioral Surveillance System in the 5 items assessing suicide-related behaviors. So consistently, we see these disparities in mental health outcomes affecting racial and ethnic minority youth. In terms of the suicidality context in the US, we all know that suicide completion remains a leading cause of death among teens, and rates have been rising recently in the United States overall, but also for youth. But there are 2 patterns specific to racial and ethnic minority youth that merit particular attention. One is that Latino girls report consistently higher rates of suicidality. This is a pattern that's persisted for decades, and it remains largely unexplained and unaddressed in public health. And then more recently, Bridge and colleagues found in YRBSS data from 2001 to 2015 that Black children ages 5 to 12 saw 2 times the rate of suicide compared to their white counterparts. And this discovery kind of happened because the investigators looked at stratification by age, where they didn't see this pattern overall among teenagers, but when they broke it down by age from 5 to 12 to 13 to 17, they found this pattern among younger Black children in particular, which has sounded an alarm recently at NIMH to address this alarming trend. In terms of mental health services for adolescents, there's also a large gap in unmet treatment need. Less than 50% of affected teens with mental health issues actually receive care. And this treatment gap is especially large for those in lower socioeconomic position and for ethnic minority youth. These disparities have been shown to persist even after adolescents experience severe impairment and after accounting for factors like insurance coverage and economic factors, which has led investigators to look at other barriers to treatment utilization for mental health issues among adolescents. And one barrier in particular, and that I focus on, is stigma. Stigma blocks service use and recovery, both in public and self-stigma forms. It prevents help seeking. It's been shown to have a moderate and negative effect on help seeking. And not only does it block treatment seeking for initial contact with mental health services, but it also prevents ongoing participation in treatment and recovery efforts after episodes. So it's generally a stubborn social problem that's persisted in society for decades, but it's also preventable. So the good news is we could do something about it. The reason why I focus on children and adolescents for mental illness stigma prevention and early intervention is because it's a critical period for prevention in particular. Onset of mental health symptoms often begins in adolescence, and therefore the first opportunities for help-seeking experiences also start in childhood and adolescence. Among children and adolescents, there's also large variation in views of stigma, which demonstrates that there's still malleability among this population for changing negative attitudes and behaviors towards mental illness. And if these attitudes and behaviors aren't intervened on during this critical period, it's possible that they can crystallize and follow young people into adulthood, which would have even greater negative effects down the road. Also, as early as 10, 11, 12 years old, we're already seeing racial and ethnic and gender differences in mental illness stigma. So these disparities exist at very young ages. Focusing on children and adolescents is also an opportunity for early intervention. Studying children and adolescents in terms of mental illness stigma prevention can help inform new anti-stigma strategies for the population, can assess whether or not anti-stigma population efforts that have been largely developed for adults, like PSAs or campaigns, have actually reached younger populations. And then just in general, more research is needed in this area because the literature focused on stigma research among children and adolescents focuses or uses qualitative methods predominantly, and then focuses on clinical and college age samples only. So there's a large gap in this literature base. The good news, as I mentioned, is that efficacious anti-stigma interventions exist. In a meta-analysis of 79 anti-stigma outcome studies, Corrigan and colleagues evaluated different anti-stigma strategies of education, contact-based, and social activism approaches. Education-based strategies challenge inaccurate stereotypes. These can be PSAs, podcasts, books, websites, other mediums. The advantage is that they're low costs and they can have potentially broad reach. There's also contact-based interventions where individuals from the general population interact with those with mental illness. One example is the NAMI peer-to-peer program. And the advantage with these interventions is that they permit grassroots control when they're conducted in person. And then there's some examples of social activism being effective, particularly for reducing harmful media representations. And what this review, this meta-analysis showed was strong internal validity across these studies, that both education and contact-based interventions work overall for the population. For adolescents in particular, education-based interventions work the best, more so than contact-based interventions. However, when I was reviewing this meta-analysis, I was really fixated on the first table, the table 1. So this meta-analysis included over 38,000 participants worldwide, but the table 1 showed some very unique patterns in who become recruited to participate in these efficacy trials. So these trials occurred among 61% European American populations compared to 21% African American, 6% Latino American, and 6% Asian American. Also, less than 1% of these trials included children under 12 years old, and they tended to recruit more women compared to men. So in terms of general